Welcome to part 1 of hyponatremia treatment. Today we're going to discuss the use of 3% normal saline in hyponatremia, when and how. If you would like to receive a summary of this video, please subscribe to my Substack page. The link is provided below. Let's start. First, let's talk about 3% normal saline. As you probably know that we can make normal saline by mixing the 0.9 normal saline by mixing 9 grams of sodium chloride tablets in 1000 cc of free water. So to make 3% normal saline, simply 9 times 3, we mix 27 grams approximately of sodium chloride in the same amount, 1000 cc of free water. So the osmolarity of 3% NS will be 3 times the osmolarity of normal saline, which is 308, which means 924 milli equivalent, right? Which is extremely hypertonic solution. And this is the fastest way to increase sodium concentration, because assume this is the ECF, so you're adding a very large load of sodium, you increase the sodium amount with the same amount of water. What's going to happen to the sodium concentration? Will go up. So this is the fastest way in clinical practice to increase sodium concentration whenever it's indicated in severe hyponatremia or symptomatic hyponatremia, as we will discuss soon. But despite the severe hypertonicity of 3% normal saline, remember that we still can give it through a peripheral line. We'll come to that soon. Let's talk about the indication of 3% normal saline in hyponatremia. And I think it's best to start with the cases where 3% normal saline is not indicated. Remember, the 3% normal saline is only indicated in hypotonic hyponatremia, which means the 3% NS is not indicated in isotonic hyponatremia or hypertonic hyponatremia. As you know, we said this is a artificially low sodium concentration, so there is no clinical implication, no treatment required, and the hypertonic hyponatremia does not cause symptoms related to hyponatremia. So there is no worry of hyponatremia related symptoms or worries about overcorrection in hypertonic hyponatremia. Also, it's not indicated in mild hyponatremia, which means if the sodium level is equal or more 130 milli equivalent per liter. Rarely, if any, hyponatremia will cause any complication or symptoms if it is mild, if the sodium concentration above 130 or above. So if you see the sodium level is 130 or above, do not think of using 3% normal saline. So what cases in hypotonic hyponatremia 3% normal saline is indicated? Because not all hypotonic hyponatremia needs 3% normal saline. And here we need to understand the concepts of acute versus chronic hyponatremia. Acute hyponatremia is the hyponatremia that develops within 48 hours. And the chronic is the hyponatremia that been for more than 48 hours. And that's why chronic hyponatremia is much more common compared to acute hyponatremia. I want you to understand the risk of symptoms, developing symptoms is much more, and complication is much more with acute hyponatremia, because there is no time for the brain cell to adapt. So they swells quickly, they increase intracranial pressure quickly, and risk of herniation is much higher. Compared to chronic hyponatremia, the brain cells has the time to adapt. The symptoms are way less compared to acute hyponatremia. Now, the risk, on the other hand, the risk of osmotic demyelination syndrome from overcorrection is much higher in chronic hyponatremia. Actually, we don't worry about that much in acute hyponatremia, but we really worry about overcorrection and the osmotic demyelination syndrome in the chronic hyponatremia. So again, the risk of symptoms and complications is much higher in acute hyponatremia, no time for the brain cells to adapt. The risk of osmotic demyelination syndrome is much higher in chronic hyponatremia. So when to suspect acute hyponatremia? Either that we have a patient who's admitted and we see sodium on day 1, and then we see the sodium drop on day 2 or day 3, we have a baseline to compare to. And this is mainly happens in postoperative patients, where the postoperative state induce ADH secretion, increase in ADH, and they receive hypotonic IV fluid solution. That's why in postoperative patients, hypotonic IV fluid solution should be avoided. And you will never find a surgeon who use hypotonic IV fluid solution in post-op patient. Use isotonic solution only if needed. Now, the one exception that I may get patient the ED and I suspect acute hyponatremia is water intoxication. Marathon runners, I don't expect them, they've been drinking for weeks. Probably they ran a marathon and they drank drank too much water, right? When you see these conditions, deal with it as if it's acute hyponatremia, even if you don't have a baseline to compare to. Other than that, any patient that comes from home with hyponatremia, assume it's chronic, except in these cases. It's also important to understand the severity of hyponatremia. We call it mild if the sodium concentration is equal or above 130 milliequivalent per liter, moderate between 120 to 129, and severe if sodium is less than 120 milliequivalents. So remember the severity. Remember, the severe hyponatremia is sodium less than 120. It's also important to understand the symptoms of hyponatremia, and mainly I want you to know the severe symptoms. Seizures, coma, obtundation, respiratory arrest, these are severe hyponatremia symptoms. Now, mild to moderate symptoms include headaches, fatigue, lethargy, nausea, vomiting, gait disturbances. And remember, you rarely develop any symptoms in mild hyponatremia. If you have symptoms, think of other causes other than hyponatremia. Let's talk about the use of 3% normal saline in acute hyponatremia. We agree now that acute hyponatremia is much more dangerous than chronic hyponatremia because there is no time for the brain cells to adapt, right? So the main reason to use 3% normal saline, or the main targets of treatment, is to relieve any symptoms and to prevent any further decline in sodium concentrations. So we use 3% normal saline in acute hyponatremia if there is symptomatic, regardless of the severity of symptoms. Here in acute hyponatremia, any kind of symptom that you suspect is related to hyponatremia, even mild, go ahead and use 3% normal saline. Now, asymptomatic patient, also we use 3% normal saline if there is no self-correction. So what is this self-correction? Basically, a lot of patients automatically, when they come to the ER and the offending agent and the cause of acute hyponatremia is stopped, the sodium levels start to improve on its own. That's self-correction. So how do I tell if there is self-correction or not? Of course, some they say monitor urine output, check specific gravity, etc., which is going to be confusing in real life practice. What you do, repeat sodium in 1 hour. So make sure to get a sodium level in 1 or 2 hours at the most. I recommend 1 hour. And if there is no improvement or there is worsening, decline in sodium level, then that means there is no self-correction. Otherwise, if there is improvement in the sodium level, then there is self-correction. So it's very important. Repeat sodium level in 1 hour. If there is no improvement or there is decline, then there is no self-correction. Go ahead and give 3% normal saline. If you repeat in 1 hour and there is improvement in sodium, continue monitoring without giving 3% normal saline. How about the use of 3% normal saline in chronic hyponatremia? As you know by now that there is less risk for symptoms compared to acute hyponatremia, but much higher risk of osmotic demyelination syndrome in chronic hyponatremia. So give 3% normal saline in chronic hyponatremia if there is severe symptoms. So not mild or moderate symptoms, only in severe symptoms. And remember, we said seizures, coma, obtundation, respiratory arrest, etc. So mild to moderate symptoms in chronic hyponatremia, we don't give 3% normal saline, unlike acute hyponatremia. Now, the exception, the presence of intracranial pathology. Here, whether it's mild or moderate symptoms or asymptomatic, we give 3% NS. And the reason the presence of intracranial pathology, whether a tumor, recent surgery, hemorrhage, will make it easy for the intracranial pressure to go high. And severe hyponatremia, sodium level less than 120, regardless of the presence of symptoms or not, these patients also we give them 3% normal saline. And we'll explain how we do that very soon. Now, we decided our patient needs 3% normal saline. How do we monitor that? We admit to ICU. This is highly preferred. Now, maybe acceptable to admit to intermediate care unit or step-down unit if asymptomatic, but check your hospital policy. Neuro checks frequent every 1, 2, or at the most every 4 hours. The goal is to increase the sodium level 4 to 6 milliequivalent in 4 to 6 hours, or faster even if they are symptomatic, to relieve the symptoms, right? And then keep it there for the next 18 hours. This is very important. We try to achieve this very quickly, right, to relieve symptoms, but we need to keep it there for the next 18 hours as well, and I'll discuss this soon. The rate of correction, again, we learn forever to keep it around 8 milliequivalent 24 hours. I prefer the 4 to 6 milliequivalent. That will give us a room if we go beyond that, but shoot for this target. That will give you a room for 1 to 2 milliequivalents to go above that. Check sodium level every 1 to 2 hours while on 3% normal saline. Make sure it gets done on time. Now, when do you stop 3% normal saline? Once the increase in the sodium level by 4 to 6 milliequivalent. Now, the increase in 4 to 6 milliequivalent is usually sufficient to relieve any symptoms. If the patient is still symptomatic after 6 milliequivalent, think of other causes other than hyponatremia. And very important, stop all other IV fluid solution while on 3% normal saline. Should be only 3% normal saline, except in one case I will discuss soon that will give us full control and predictability about the rise in sodium concentration. Now, how do we give the 3% normal saline? In acute hyponatremia, we said symptomatic of any kind of symptoms, we give 100 ml of 3% normal saline infused over 10 minutes and repeat times 2 if needed. Remember that we can give it through peripheral line. We don't need central line to do that. Now, what do I mean if needed? Until symptoms resolved or at least significantly improved. If patient is seizing, the seizure has stopped. If the patient is obtunded, the patient started getting more awake and more alert. So you gave the first one, symptoms still there, we repeat the second one, symptoms still there, you repeat third one, but no more than 300 ml total. Asymptomatic with no autocorrection, as we explained, that you repeat the sodium level in 1 hour if there is no improvement or decline. Here we give only 50 ml of 3% infused over 10 minutes times 1. Now repeat the sodium level in 1 hour or 2 hours as we explained. If there is still decline, then you may repeat this again. The goal is to prevent further decline. That's the whole goal or the concept behind giving 3% to asymptomatic with no autocorrection in acute hyponatremia. Now, once the 3% is not needed anymore, you can switch the monitoring from Q1 to 2 hours to Q4 hours or to 6 hours. So I prefer Q4 hours of sodium. But while we're still thinking about giving 3% normal saline or giving it, we have to be very close every 1 to 2 hours. Now, how about the use of 3% normal saline in chronic hyponatremia? If severely symptomatic, as I said, we give 100 ml of 3% normal saline infused over 10 minutes, as we just explained, and may repeat time 2 doses with maximum 300 ml total if needed. If symptoms persist, if the symptoms resolve or improve significantly after the first one, no need. If they persist, you can give a second dose. Still there, give a third dose, no more than 3 doses. And remember the goal, symptoms improve significantly or resolve, or the target of 4 to 6 ml equivalent is achieved. Now, intracranial pathology is exactly the same here. 100 ml infused over 10 minutes, you can repeat time 2 doses. If the patient is asymptomatic here, the goal is to achieve the increase in 4 to 6 ml equivalent in sodium concentration. This is the cutoff will be if the patient is asymptomatic. Now, in severe hyponatremia, if the sodium less than 120, if severely symptomatic, we use this protocol here until the symptoms improved. As I said, you can repeat times 2. Now, to achieve the 4 to 6 ml equivalent, if it's not achieved by 3 doses, we use this. And we use this also if asymptomatic. So 1 ml per kg, let's say 100 kilo patients, we give 100 ml. The maximum is 100 ml. So if the patient is 120 kilo, we give 100 ml. And it's a bolus every 6 hours. Other protocol, this is in up-to-date, both of them, and I prefer to use 20 cc, 15 to 30 ml per hour. I prefer 20 cc an hour. Continue checking sodium every 1 to 2 hours, and once you achieve the 4 to 6 ml equivalent, you stop 3%. Not to getting you confused. If asymptomatic here, use either the bolus every 6 hours or the continuous infusion and monitor sodium to achieve the 4-6 ml equivalent. If they are symptomatic, follow this protocol until the symptoms has resolved. Let's say the symptoms has resolved, the patient's sodium was 110, and then the symptoms resolved and the repeat sodium was 112. I will continue this until achieve the 4 to 6 ml equivalent. Now, let's assume that the patients continue to be symptomatic and the patient is at 4 ml equivalent. Go to 6, no more than 6. Remember what I said? If the symptoms persist despite increasing sodium level 6 ml equivalent, look for other causes. One important thing to remember that we use 3% normal saline in chronic severe hyponatremia regardless of volume status, which may seem counterintuitive that we use 3% in hypervolemic patient, right? They are already fluid overload and we give them large load of sodium that will only worsen their fluid overload. So we can give diuretics with the 3%, but you still use 3% if they meet any of the criteria as we discussed, even if they are hypovolemic, or you give them loop diuretics. Also, volume depletion or hypovolemic, we use 3% normal saline. Now, again, you may say, why don't we use isotonic solution? We try to avoid that because 3% will give us much more predictable rise in sodium level. Now, the only case, let's say the patient is hypotensive or having orthostatic symptoms or having acute renal failure from prerenal azotemia, then I have really no choice. These signs of hemodynamic instability, he may go into full hypovolemic shock. In these cases, we can give 3% NS plus normal saline 0.9 or lactated drinker, an isotonic solution together. I may give a bolus or two of the isotonic solution to improve these symptoms and then just stop them and rely on 3% normal saline. Now we mentioned that we worry about the overcorrection and risk of osmotic demyelination syndrome in chronic hyponatremia. That's why you will not see us talking about this in acute hyponatremia. We said the goal is to increase sodium by 4 to 6 milliequivalent per 24 hours. And this is a safe goal. As I said, that will give you a margin of 1 or 2 that you go beyond that. But this should be your goal. If the rate of correction is above 6 to 8 milliequivalent, you have to slow it down. Otherwise, there is a risk of osmotic demyelination syndrome. But do I worry about overcorrection and risk of osmotic demyelination syndrome in all cases of chronic hyponatremia? No. There is particular cases that the overcorrection can be. There is particular cases where they have high risk of overcorrection and high risk of osmotic demyelination syndrome. And these are the people that we need to recognize and try to institute therapy to slow down the correction of hyponatremia. All right, condition that likely correct quickly, volume depletion, and this is the most commonly encountered. I come to see them in the ED. They're already giving 1 to 2 liters of isotonic solution and their sodium level can correct quickly. Adrenal insufficiency, also once you give them steroids, it corrects quickly. SIDH, except the chronic one that you know a patient from previous admission has issue with SIDH, and also hyponatremia from thiazide diuretics. Once you stop thiazide, they usually get some fluid isotonic solution and they correct quickly. Now, patient with hypervolemic or fluid overload or volume overload and chronic SIDH, there is really very low risk of overcorrection and we don't have to worry much about it. Now, condition with increased risk of osmotic demyelination syndrome, and remember this is mainly in chronic hyponatremia, severe hyponatremia with sodium level less than 105. This is really high risk with overcorrection. Concurrent hypokalemia, alcohol abuse patients, acute and chronic liver disease, malnutrition. So if you have any condition that has increased risk of a quick correction or any condition that increased risk of osmotic demyelination syndrome and you're dealing with chronic hyponatremia mainly, avoid overcorrection. Please remember, in these patients particularly, 46 milliequivalent per 24 hours. But how do we achieve that, especially if we're giving 3% normal saline? Now, how to avoid overcorrection? We have to be proactive in such cases. That's why it's recommended that we use Desmopressin, which is kind of an ADH analog. Simultaneously, actually, before you start 3%, you can give Desmopressin in these conditions. As I said, the rapid correction or high risk of osmotic demyelination syndrome. So you give them simultaneously, and then it's 1 to 2 micrograms sub-Q or IV every 6 to 8 hours for 1 to 2 days, and stop when the sodium is equal or more than 125. And very important, restrict water intake. If you use Desmopressin, you have to restrict water intake, and I'll talk about fluid restriction, what kind of fluid restriction next video in the second part of hyponatremia treatment. If you cannot guarantee there will be a water intake, let's say the patient is psychotic or something, do not use Desmopressin. Remember that very well. Now, also it's important to mention that some patients who already take Desmopressin at home, like patient with diabetes insipidus, I think they changed the name of the DI now. Those patients, if they come for hyponatremia for any reason, do not stop Desmopressin. All this seems counterintuitive, but please, while you're treating hyponatremia with 3% in them, do not stop, because otherwise, once you treat the cause of hyponatremia, their sodium will be very quick and they become hypernatremic in no time. So continue their Desmopressin. Now, very important that if we decide to use Desmopressin, the use of 3% normal saline along with Desmopressin can give us a very predictable increase in sodium level and controlled increase in sodium level and avoid overcorrection. Usually we give 0.25 per kg per hour, and this is mil here, So 100 kilo patient will get 25 mil per hour, right, of 3% normal saline along with desmopressin. But how about the things that we said we give if patients symptomatic, we give 3% 100 cc and then repeat up to 2 doses. You do that, or everything we talked about it earlier, you do it. And if I decide to use desmopressin, it's better that I use continuous infusion of 3% normal saline along with it, again, 4 to 6 milli equivalent per 24 hours. That's one thing. The other thing, you still can use desmopressin. Let's say you give 300 cc of 3% normal saline to a patient and his sodium increase already by 4 to 6 milli equivalent. Now, how about using D5W and free water to prevent overcorrection? It can be used, but as I said, it's not as effective and as predictable as desmopressin. And the problem with D5W, they mean increase blood sugar, glucose, right? Blood glucose, worsen hypokalemia, and in alcoholic can worsen thiamine deficiency because the D5W stimulate insulin secretions. But we've done it sometimes, and it's very hard to catch up, to be honest with you, when you use D5W. We can go as high as 150 cc an hour and still not catching up. And sometimes we start telling the patient, drink this amount of water to catch up. But it's a strategy that can be used, but I prefer desmopressin if it's available and you are comfortable using it. And we come to the end of this video. Next, part 2 of hyponatremia treatment, where we will discuss the treatment of mainly chronic hyponatremia where 3% NS is not indicated, and also discuss the treatment of hyponatremia once we are done with the 3% normal saline. A lot of important topics to be discussed next video. If you like this video, please give it a like and share it with your colleagues. And if you'd like to receive a summary of this video, please subscribe to my Substack. The link is below. Thanks for watching and see you next video.